All set.
All right. Good afternoon, all. Welcome to the Wednesday, July 15th Health and Human Service Committee meeting. This is our official call to order. There aren't really too many changes to the agenda. I'm going to reorder some things. We have some department heads moving today, so I want to get them in and out. I have a lengthy conversation for the chair's report. So we're just going to hop around a little bit, if that's okay with everybody, so I can get department heads in and out. Is that any problems? Cool. All right. Everybody's right here. This is all right. Minutes approved. Oh, public comment. We have two folks for public comment. We'll start with Pei, who's here in the building. Come on up, Pei.
Thank you. Good afternoon.
Good
I just
afternoon.
made it in on time. My name is Pei Shoinka. I'm the chair of the Human Rights Commission. We would like to commend the county's stakeholder search committee for the human rights program manager for the work they've done, and we're looking forward to meeting the finalist for that position later this month. I just also wanted to mention that the commission currently has, we're very fortunate to have 3 attorneys working as members of the commission, so thank you for approving that. And we also have a legal intern who is joining to help us we're creating a Q&A for the community that's accessible, where they break down the legal language of basic things that affect them and give links to resources that might be useful on issues ranging from housing, healthcare, and other areas. So it's very exciting for the commission at the moment. But today I just wanted to speak to the need for this new electronic health record system for the whole health department. I was very excited when I saw that on the agenda. And over the past few years, several years actually, I've had the privilege of supporting many members of our community, in particular young people from disadvantaged backgrounds, in seeking help, particularly when our campus counseling centers are just backed up, and getting them down to the mental health department and seeking access. It's often involved driving them there, staying with them while they try to stay professional, helping them in giving courage to answer forms and so on. And through my organization, paying for private counseling services, which are more flexible. Over the past year, we've been supporting an adult member in our community, a professional, incredible person who has faced a physical limitation and then accompanied by emotional mental health issues, preventing them from physically leaving the house. So when I saw the description of the new electronic system, including possibly a portal, patient portal, where they can actually share what's going on, ongoing needs with clinicians, I thought this was really a godsend. I can think of many members in the community who, in particular in seeking emotional and mental health care, would find it very useful to be able to document, correspond, communicate, particularly when it affects, they don't have to leave the house immediately and can get encouragement in doing so. So I just want to encourage the county. I think this, I'm not sure what the expense would look like, but I know that in terms of human well-being, it will be a godsend for many members of the community for us to have a much stronger, more robust, accessible healthcare, electronic healthcare system. So that's kind of what I just wanted to really emphasize today. Thank you very much.
Thank you. Just an update. We are in the process of hiring for the program manager for Office of Human Rights. We are at a place where we're getting ready to do second interviews, so we are moving right along. And hopefully in August, we'll be offering a position to somebody, and we'll be back on track and moving forward. So we're really excited about the candidates and the possibilities. Up next, Zach Wynn.
Hello, thank you very much. My name is Zach Wynn, and I live right downtown, just a few blocks from the Commons. I'd like to make the committee aware of a rat's nest that is next to the Tompkins County Public Library underneath the power transformer, very near the TCAT bus stop. The library is aware. I've made the county aware for quite a while now, and the site just continues to grow. There is a feeding frenzy going on every night at the Hotel Ithaca dumpsters, and I was wondering if the county has any sort of coordination with the city and private stakeholders for dealing with pests and vermin. I've noticed an increase in pests downtown. I saw what I thought were a great deal of cockroaches on the sidewalk outside of the Asteria the other night, which is incidentally much cleaner inside. And I forwarded photos of the rat's nest, as well as a video that appeared to show what I initially thought were cockroaches coming out of the pillar next to the TCAT bus stop by the overhang. I'm also told they might be cluster termites. Looking into the cockroach issue, I've been told that the Tompkins County Public Library is infested, rather, and that as it's operating as like a daytime homeless shelter, there's sort of a rotating presence of cockroaches at the library and at places like the Roadway Inn. I'm told that, I don't want to name any names, but some nearby businesses to the Asteria have a cockroach infestation. So I'm wondering, again, if there's any sort of coordination and like a dedicated pest management strategy, because this kind of spans city property, private property, county property, and a county service. I can actually send you a picture of a cockroach on a TCAT bus catching a ride. And I'm sure you can understand how if the bus station itself was to be teeming with cockroaches, that would be a major problem. Also, I'm just curious if this smog from Canada is going to become a yearly thing. I didn't notice that much as a child, and now as an adult, it's happening year on year. And is there anything that can be done to encourage Canada to better manage their forestry? That's kind of a secondary issue to the roaches and the rats. So thank you very much for your time.
Thank you. That is it for public comment. All right, we are going to move to minutes approval for the June 7th, 2026 meeting. Do I have a mover? Christie moves. Mike seconds. All those in favor? And that is unanimous. County Administrator's report. Where is Bridget? Didn't I see Bridget?
I saw her.
She floated in and floated out, huh?
She was on the phone in the entryway when I came
okay.
in. So
We'll swing back to Bridget. For my chair's report, there isn't much this month. There's a conversation that we're going to have a little later in the agenda with TC Action and Lydia and COC. So I will skip that. How about we go to Lisa Monroe, who is moving today. There's no resolutions. Lisa, do you want to share any updates with folks? And then you could get back to doing the big lift.
Yeah, no updates other than the move at this point. It's kind of all I can wrap my head around at this point, honestly. And we're getting there. Things are kind of going as smooth as possible. And we hope to be in place and pretty functional by Monday, the 20th. So yeah, crossing fingers. So, but it looks good up here. So thanks for all your support.
Absolutely. Any questions for Lisa? All right. Thank you, Lisa. We're not going to keep you. I know you're busy.
Okay. Thank you.
Absolutely.
Take care.
Jenny, why don't you come on up from Whole Health?
Thank you, everybody. We have two presentations today. The first is on just an update on the fact we're going to be issuing an RFP for a new electronic health record. So I wanted to kind of share some background on that. And then we have Marie, who's joining us to give a presentation on her reentry work. Any particular order you want to do those things?
No, it's up to you.
Okay, let's do the health record first, and you've got the slides.
No, you would pull them up and hit share to
Oh, I
present?
pulled them up and hit share. Okay, why don't we start with Marie then? Sure. And then we will do the health record and I will find them.
Yeah, I don't have slides. I'm just going to talk. I believe that the 2025 annual report was sent out to you guys. Okay, wonderful. So I'm just going to go off some main points there. I'm not going to read through the report. It's a lot to talk about, but I want to leave some time for questions because we always have a decent amount of questions. So I work at Tompkins County Whole Health. I provide services in our Tompkins County jail to folks that are being released there. So I work in and outside of the jail. So recording in progress. So, good. So in 2025, I provided services to 154 unduplicated people during that year. And that's through a combination of outreach and enrollment with reentry. Enrollment, so a lot of folks will be outreach at the jail when they don't necessarily know what the outcome of their cases are going to be. So that's why there's two separate numbers on that. When somebody realizes what the outcome of their case is going to be, then they can voluntarily enroll to work with me ongoing through the transition of release for 60 to 90 days after getting out of jail. So that's why we have two different numbers and kind of the background behind that. So with that, 77 participants of the 154 ended up enrolling for ongoing support and reentry case management through my services. A lot of what I do, because it's a transitional program, it's short-term, the goal is to get folks connected to the services in our county upon reentering our community. So most of the work is made around providing referrals to meet the needs that folks may have upon their release, okay? So during that whole year of 2025, there was 348 successful referrals that were made. I break down the referrals into several groups to try to give a good snapshot of what they are. So 132 of those referrals, we break out into what's called an entitlement program. So that would be any services related to housing, Social Security, DSS benefits, anything like that would be considered into the entitlement program numbers with that. So there's 132 for that last year. 48 referrals were made to the wellness programs. Wellness programs can be anything from mental health treatment, substance use treatment, helping somebody find a primary care physician, dentist, vision care, health navigators. It could be referring somebody to care management through Health Homes of Upstate New York. It could be referring them to New York State of Health for insurance issues or suicide prevention crisis service. Anything related to a wellness piece would fall into that category. 24 referrals were made to readiness services. Readiness services tends to be stuff related to educational and employment referrals. Those always fall on the lower end because you tend to not, like with wellness, you can make several referrals. Like you need dental care, you need vision care, you need this, so you have a handful of referrals. With employment and education, it's usually limited because people want to focus on one job or, you know, one educational goal. So that's why those numbers tend to be lower. A little bit of explanation with that. And then the remaining referrals were made to all the other community resources that our community offers. Any questions about any of that so far before I go on? Okay. I keep track of contacts. So contacts would be anything like a contact with the person physically in person, could be on the phone, could be a collateral contact. So I keep track of all those contacts for the whole year. And we had 2,264 contacts for 2025. I also take a good look at the housing. What's happening with people when they're released? Are they entering the shelter? Do they have stable housing? What is that looking like? So of the people released, which were the 69 of released at the time this report was due, 43% of those people were unsheltered. And, well, that should be 64% have secured, well, 63% have secured housing since their release. The status of paper involvement at release for those enrolled with reentry, the majority of folks that I provide services for are not on paper. They're not on probation. They're not related to drug courts or anything like that. That was part of why I think this program came to fruition, was because there was a gap. So folks that are being released, maybe serving out sentences and just coming out and don't have any ties to anything related to the criminal justice system is the bulk of the people I serve. The average length of enrollment is 6 months. When you take a look at the recidivism, it's about 10%. We use the rebooking rate at the jail because we struggle with finding any other way to do the recidivism at this point. Some of the other random things that we did, winter coats for release this past winter. I teamed up with Catholic Charities because I was unable to find enough donations to provide all the winter coats that we needed for folks coming out, because a lot of folks came in the summer and didn't have any winter gear when they were coming out. So Catholic Charities was amazing and actually went out and purchased all the coats that I needed for folks that were coming out if we didn't have them in donations. So that was a really great thing that they did for us. I started re-entry groups at the jail in October this past year. It's been something I've wanted to do for a very long time. Space presented itself for me to do it, and the jail therapist, Joanna Sturgeon, who is my partner in all of this, she has to be present for the groups because I'm not employed by the jail, so she is present in the groups, and she's been a big supporter of this, and without her, I could not do these groups. So starting in October the past year, 37 people were served through the groups. Most people attend multiple groups. And we have a group every Tuesday afternoon is when we do the groups. When I first started in October to introduce the groups to people and stuff, one of the first meetings with folks was like, what do you want in the groups? What would be helpful to you? And different things like that. And everything, I mean, lots of different things came up. The housing, getting back in school, employment, food resources, support groups for people who generally care on the outside when you return home, activities in the community for the reentry population, PTSD, bipolar support groups, goal setting and achievement, substance use, mental health recovery, and temper calming strategies were the stuff that people requested. Last year, from October on, we did different topics based on what people wanted. So we did a lot of temper calming strategies and anger management. We did so much on substance use recovery, relapse prevention, dealing with cravings and addiction. We did a lot and continue to do all these things throughout this year as well. Mental health recovery, mental health's role in recidivism when it's untreated. A lot of discussion in groups about that, actually. We do stuff around employment, providing information on the Clean Slate Act, which a lot of folks were unaware of. Law New York, resume tips sheet. People also can do a rough draft of their resume, and if they hand it to me, I can get it typed out and ready for them to go before they get out. So we also work on that. We also discuss the different employment programs that are available in Tompkins County. We talk about the reentry barriers and tools and way to overcome the barriers and what can help. I provide housing and shelter updates, you know, as things happen in our community that people aren't aware of when they're behind bars. I've connected with one of the folks in our community doing the 1115 Medicaid waiver, and they've started going up to the jail with me to meet people that were eligible for the waiver so they can have that connection getting out. I made a handout that I can give to everybody getting out, and also provided that information to the Sheriff's Department. And we do worksheets on making your reentry plan, and that's something that we also do in the groups. And that's all I have written down. So give me some questions, please, Christy.
Go ahead, Christy.
Thank you. Well, first of all, I want to point out this is extraordinary because you're one person, and you look at the amount of contacts that are coming out of.
She puts what I do in a day to shame.
Oh, but I mean, really, truly, it's an amazing amount of work, and it's so critically important. And it's just very eye-opening when you realize we have one therapist working in the jail, and we have you doing all of the reentry work, and it's just extraordinary. And the numbers really show how effective it is. The question that I have is, right now, if somebody gets released paper-free and they don't have housing set up, walk me through 48 hours. The next 48 hours after that release, what happens to that individual?
So if we have a sentenced out date, which is very helpful, So we know they're getting out on that date because DSS's response is different based on that piece of this information, okay? So if they're sentenced out with the sentenced out date, I am able to do the application for temporary assistance, which is the shelter, right, THA, the food stamps, and the public assistance, if they want all of them, and submit that 2 weeks prior. I have a contact at DSS that schedules the day of release for that person to come in there, and that's when they apply for the THA and get the approval, and then they would be sent, well, now, because Cold Blue is closed, they would have to go to the DSS for that approval, and then from there, most folks are going to roadway, but I think it depends on different situations like that.
All right.
In the event that they can't get the THA approval, they're on the streets.
Okay. I mean,
unless our Cold Blue is open. So that's always an ongoing problem due to sanctions and everything else.
right. That's good. I mean, it's the system, and I know we don't have the hard numbers, but it was good just to see like the walkthrough and how all the pieces are fitting together. And so I think I'll probably process that more and come back with more questions about that. But I mean, the other thing I noticed that it's a really pretty small number of people when we look at the recidivism rates, but you were able to identify this is what's happening, right? There's a substance use issue, there's a probation violation happening. As of right now, for that small group of people, and I recognize that it's small, what do you think is driving the recidivism? Are you working with probation or the treatment courts to really identify for that group of folks what's happening?
What I see, that I feel is driving it, I think that a lack of housing is a big driver. People don't have a safe place. So we have a lot of folks, and this will come out in the groups a lot of folks are working hard on their recovery up there. It might be jail, but they're doing everything they can. Joanna and myself are providing as much as we can around that in that setting. So they will work hard on their recovery and put their hearts into it. Coming out into Ithaca, even if you are approved for THA and shelter, and because the shelter stays are so very long, it seems now, that is really challenging to maintain your recovery in a setting that you can't just go home and be safe. You're at the whim of everything around you. And I think that the combination of the lack of housing, the substance use, the recovery piece is big. I think it's the main drivers, in my opinion, what I see.
Okay, thank you, Marie.
Do any others have questions? Rachel?
Thank you for the report, and it's probably in here and I missed it, but just to clarify again, you're saying that 47% of people after they're released remain unsheltered. Is that right?
Okay. So the people that were released unsheltered were 43%. Yep. Yeah.
Okay, and then the other group of people, they're people who maybe had stable housing before going into jail and they're able to return to that housing?
Yes.
Okay.
And that other number, that 63% have secured housing since their release. So you'll see the 19 out of 30. So you have 30 folks that were unsheltered, right? And then 19 of the 30 secured housing since their release. So a bulk of them did.
Okay.
But there's certainly a lot that didn't.
Yeah, and you said that you're in touch with them, or they're in touch with you 60 to 90 days after?
Post-release.
Post-release.
Yeah,
right.
Maximum is supposed to be maximum.
Okay.
Unfortunately, sometimes if I lose, sometimes people, you lose them, they're MIA, you can't find them, right?
Sure.
Sometimes I go over that. That's why the average enrollment is actually 6 months.
Okay.
Because I tend to go over that. I don't like closing people if they don't want me to close them because they still have unmet needs. So that's one of the things I really struggle with. I don't know, in my job, I don't like it. And then I feel like I have to do it, so.
And have you seen programs in other communities that you feel like do a better job supporting people who would be unhoused when they're released. And like, if they're not, being put directly into a shelter system or a THA, like, what are other places doing that's working better?
Well, I shouldn't say a lot. I think some other communities have a lot of more halfway houses, transitional housing, recovery houses. I think we're very limited in our county with that kind of stuff. We don't have a lot for folks, like, even for folks that are coming, like, they might go door to door from jail straight to an inpatient rehab. And then trying to, plan for those folks coming back into not shelter, but into a safe space, a recovery home or something. We lack that. We lack that big time. I've been to communities. I have a family member that lives and works down in Pennsylvania in an inpatient facility. And I was blown away by seeing that community and all the recovery houses. Like, there's no wait list because there's so many. You know what I mean? Like, it blew me away. And they do better because of that, The relapse rate is much lower when you have those supports to help you through it, And people feel so alone here,
And do you have a sense, do people then, do they need like 6 months in a recovery space? Like when you're looking at other places too, like what does it look like the kind of runway is for people if they're coming out of jail and they're going into a halfway house or a recovery house?
I think it's really person for person, but I think long-term is, if you get to the point where, and this is another thing I feel that addiction's driving folks to being jailed. I feel like a lot of the stuff that's happening with the alleged crimes that someone may have committed is very much related to their active addiction. That being said, usually when you reach that point in your addiction where you're going, where's it gonna get you, jail or death, right? When you get to jail, your addiction's pretty hard. It's pretty severe. So in that particular case, I would think that longer term is better. I would think, but everyone's different. So and recovery is very individual based. But I think in my experience, the longer term is better. And you can have somebody, I've seen it happen here. Somebody did a long term, 6 to 9 months, came back to Ithaca, relapsed because they could not get into housing that was safe, that was recovery. They had to go into the shelter. They had worked so hard on their, it's very, it wasn't good.
Unfortunately, we hear that story too often.
Yes, we do.
Of folks coming home and can't get housing, can't even get into the shelter that night, and end up in the same places and around the same people that they were around before they went to jail. And it's almost inevitable.
And that's when we lose them too. Because when you come out of jail and you come out of rehab, you're highest risk for overdose. That's when we lose them,
Did you have any more follow-ups, Rachel? Marie, over the last, some time now, since I've been involved in LEAD and then on the legislature, and talking to outreach workers, folks that I work with in the LEAD program, your name comes up all the time for reentry. Everybody's like, well, you got to go talk to Marie. She has all the information. She does this, she does that. She does it all by herself. Of course, I may get mad at this next question, but that's too bad for him. I always wonder, in spending years at nonprofit, we always make this argument that if you do more on the front end, it costs you less on the back end. So I guess this might be a question for you, Jenny, and you, Marie. Can more work be done if there were 2 Maries? Or even a Marie and a half? Can we do more? Can we move the needle if this wasn't all falling on the shoulders of one person? And in your professional opinion, would it save us money long term?
I would love to answer that. Yes, it would. And I'm gonna point out something that is unique to this. Going into the jail and making that physical connection, seeing people through the groups individually, making that connection is special. People are raw, people are sober,
people are in a very receptive state of mind up in the jail a lot of times. And the people that come up there to see folks in jail, that means a lot to the folks in the jail because you feel alone, you feel like nobody cares. So when you have a provider coming in to bring the services to you, just saying, I care about you, I believe in you, you know, that is an incredible difference. And that connection that's made in the jail continues on the outside. So the struggles that I have with, you know, trying to refer people out that they don't want to, right? Some folks don't want to because they've been through so much. They don't want to do this all over again, try to make the connection all over again. So my feeling, if I'm able to keep people longer, especially those folks that are like, please don't close my case, that's where the real difference can be made. But because I'm so limited, 60 to 90 days is such a limit. Like I can, you know, you can get like almost right there, right? And then you're like, oh, you know? Yes, absolutely, Travis. I do think it would make a difference. I think it would allow us to make that longer term connection to really see people through fully. Instead of just, you know, here's the referrals and you know, yeah, it doesn't feel good. And I have that request all the time. Please, like, I want to work with you. I get a call from somebody, maybe I knew them 6 months ago. I need you. I would love to, if somebody calls out for help, I think we need to help them. That's where I've always been in my life, and that's where I will remain. But I need support for that too, right? I mean, that's the reality.
And you have 77 people on your caseload, right?
Well, that's for the whole year. Usually, I mean, like, so I just did my quarterly. I think like per quarter, there's like 50 I do per quarter outreach. They're not all enrolled because some of them don't know what their cases are doing. But I think last quarter it was like 50 per the quarter.
Well, that's double what they recommend for a caseload. At the most should be 25.
Oh, yeah.
Jenny, did you want to add? Oh, sorry, Krista, go ahead.
I'm going to ask some of Veronica's questions. It seems like having a time limit on temporary housing, regardless of what the limit is, would itself be stressful for someone working on their recovery. Does that seem accurate?
I don't think I understood what the question was.
So it's asking that about time limits that are put on temporary housing.
What do you mean
Like
by
that could-
that? Temporary housing?
Well, like Rachel was asking, like how long do people stay in like a halfway house or a transitional place? And you said it was individual, but I'm imagining maybe we just don't have any places.
Oh, she was asking more like
but-
how long do
Okay.
you think? But how long they stay, Veronica? I think it depends on the program. You know what I mean? Itself.
I think it's like, is that a stressor in and of itself? Like knowing like I have access to a program, but this program is only 3 months. Is that an additional stressor?
Oh, sure.
To the participation in the program? Did I get it right?
Of course it is. Yeah.
And another question is...
Wait, hold on a second.
Oh, sorry.
Jenny, do you want to add to the question that I asked?
It's like hard to follow Marie. She's like worked on this. She's passionate about it. She's great at it. I think one sort of logistics thing that I would note is we have really seen an expansion in our forensics or sort of our justice involved work at Whole Health. And so one of the things we've recently done is actually sort of moved Marie into that forensics team. So now she is also a part of the same sort of unit that includes our care team members, our court navigator role, some of other forensics staff. So I think it presents more of an opportunity for collaboration, which would obviously only increase if we had additional staff sort of in that role, and the ability to kind of, like, she doesn't really have the time at the moment to think through other collaborations with the care team. I know you do it, but like the ability to do some of that forward planning and thinking work in having another staff person would also be valuable.
Thank you. Sorry, Christine.
Oh, that's okay. And Veronica was also wondering about folks who maybe were losing housing while they were while they were incarcerated. And do we have a sense of how often that's happening to folks who have stable housing but lose it during an incarceration period?
I think it depends on how long they're in there and if their housing provider finds out they're in there. It depends on the situation too. Sometimes if it's somebody in youth housing,
Tompkins Community Action has been amazing in holding youth housing, you know, for people. So I think it depends, are they a youth? Because there's tends to be flexibility and holding of housing for youth. I definitely had some situations that weren't good, where people did lose their housing while they were in there, lost their voucher, lost everything. Their Section 8 voucher is what I'm talking about. It depends how long they're in there, Christy. It does. If they're only in there for a month or two, they can usually slide without too much notice, but it depends.
Yeah, that's how it is with LEAD. When folks end up incarcerated, it's a short period of time. We can help usually with keeping their housing, but once we get over a few months, it is very, very, very difficult to help them maintain their housing. In some programs, you can't help them maintain their housing. It depends. So it is tough. How many other agencies or departments go to the jail to do the work that you do? Are there any? Is it just you?
The reentry piece, me.
Just you?
Just me. Reentry piece.
I know you spoke about the connection, people connecting with somebody while they're in jail. In 1991, I spent 90 to 100 days in the county, and I wasn't from here. And my only connection at that time was an OAR, whether it was the stamps, letters, getting messages to people. So I can just imagine how many folks rely on you to be able to stay connected to the outside world. I would thank you for the work that you do. I know you do it with a lot of compassion and heart, and hopefully we can figure out how to get you more help to be able to do more for people. So thank you for spending some time with us today.
Thank you, Travis, for having me. I appreciate you, and I appreciate all of you.
Absolutely.
Listening to me.
All right, we're going to have a real pivot to something that feels very trivial to talk about now, but is nonetheless important, which is our need for a new electronic health record. Thank you, Marie. Sorry, I should have really led with that. Where'd she go? I think it's clear she's a tremendous asset, and I am grateful to have her at Whole Health and really grateful to be able to bring her and join you guys in this space. All right. There we go. All right. Whole Health, we have an electronic health record. This is sometimes also known as an EMR, an EHR, an electronic medical record. At Whole Health, our EHR touches the whole of Whole Health. There are 9 programs that use it within 5 of our 7 total divisions. There are 95 staff that have current licenses for the EHR that we use, which is 1011. The EHR is pretty critical to our work in the mental health clinic, in our division of psychiatry, in our PROS program, for the care team and crisis services, but it's also just as important on the public health side. We use it for immunizations, for our Moms Plus home visiting program, safe care, rabies, TB, our community health workers use it, and then, quality assurance and improvement, finance and billing, and compliance. I think it is important to remember that we are a medical provider. We are a county department, but we are also a medical provider, both on the public health and the mental health side. We have several challenges with our current electronic health record. The current vendor has been purchased several times over and is frankly no longer updating or managing the system. There are frequent system outages that are disruptive and clinically concerning. When I say frequent, I wouldn't say once a week, but I would say probably once every 2 weeks. It may be out for some portion of the day. I will note a couple of other counties, neighboring counties, their EHRs had been down recently for several days at a time. Again, we are a medical provider, so that is something that would be pretty catastrophic for us. The current system really has sort of lack of care coordination and interoperability with other systems. It's not easy to look at treatment plans. It's not easy to see updates. We're constantly having to click through and create different forms. There's a lot of operational inefficiencies that limit data validation, and then just an absolute ton of manual billing and work that you would not necessarily expect in 2026. Manual billing, manual prior authorizations, manual insurance checks, and all of these things also really hinder our regulatory compliance. There's no patient portal, which I think is a real impact on client dignity. So that also increases the manual work. I mean, that means that folks have to call us if they want to cancel an appointment, reschedule an appointment, have forgotten when that appointment is. It means that they need to call us for their records. If they have a question about their prescriptions, they need to call. It just creates a tremendous amount of work. And it doesn't really offer the ability, especially for individuals at our mental health clinic that have complex needs with potentially lengthy medication lists, for them to, before meeting with their primary care provider, go on in, pull that medication list and bring it to meet with their PCP, right? Which is best practice and something that many of us probably do in our own care. So there is I cannot emphasize there is zero patient portal. So think of anything that you might do in a MyChart or something like that is not available for our clients or for our staff to receive the benefits of the access for that. The cost of multitasking and having to troubleshoot issues really impacts, especially the mental health clinic, it impacts clinicians' abilities to be present and really provide the best quality care. I think they sometimes feel like their ability to care for their patients is being hamstrung because of a poor EHR system that they're having to navigate at the same time. And then a lot of redundant documentation, consistent connectivity issues, and loss of work results in staff burnout and frankly, quite a bit of financial waste. I wanted to share a few staff quotes. I think this probably is the biggest morale issue at Whole Health, and so I kind of wanted to reflect that and reflect some of their thoughts about how it impacts the community. So here's a few things that they've shared. Clients who are not called by the correct name or pronouns do not feel safe, welcome, or respected in our clinics. They're less likely to use our services or recommend us to other members of the LGBTQIA community. And this is because our current system doesn't have a space and they won't create it for preferred pronouns or our preferred name. Clients are often frustrated that they cannot sign things electronically and must often wait an entire week to be able to sign an ROI or for their providers to speak to each other. This again is a pretty significant impact in psychiatry. Often our delays for psychiatry intakes are not due to because of lack of staff time or availability, but is because of the slow records transfer between providers. Many clients do not have the capability to print and scan paperwork and are understandably unwilling to sometimes drive 30 minutes to downtown Ithaca, right in downtown Ithaca with no parking, I might add, just to do one signature. At immunization clinics, if you think about when you go and get a shot, you see those nurses do a little beep beep scanner of the shot, of the paper, of you, put it all in. That is all manual work that happens at Whole Health. So that really impacts the amount of time at immunization clinics, and our nursing staff are writing things in manually in several different places. So clients wait a long time at our IMSS clinics and are often kind of unhappy about the wait. We are often unable to respond immediately to a client's request for medication refills. Often the client names and details are not understood on the voicemail. And again, this is because you can't just click for a refill, you're having to call and leave it on an answering machine, and then we have someone who calls back and manages that process. Looking forward, we will be putting together a new RFP for a new electronic health record here in 2027. I wanted to share a couple of the must-haves that we'll include in our RFP. The first is strong clinical workflows for both mental and public health programs. I really want to underscore this. When we talk to other counties, and we've been doing quite a bit of outreach and research, they all have different answers, but very few of them have both public health and mental health programs in one place. And so a lot of the sort of more boutique and specialty EHR systems work for local health departments that are just doing public health, or work for just a mental health provider, but do not work for both. So we are a little bit limited in that we need a provider that can really meet both of those needs. A robust patient portal with appointment and scheduling tools, medication lists, resources to other things. There could be an opportunity to connect to other services in that patient portal. adaptable, flexible, and modern applications. And by this, I mean telehealth, right? Currently, all of our telehealth happens through Zoom. In a new EHR, that could be something that's embedded in that system. So telehealth, AI tools for note-taking and things like that are now sort of common practice and standard across the industry. And then other modern applications, such as automated workflows for prior authorizations, for billing, records management, et cetera. Interoperability and connectivity to other providers and partners. I really can't underscore this one enough. You know, I think it's really important that we connect to Centralis, to Guthrie, to the New York State systems. NICIS is the New York State Immunization Registry. Again, that's something that we are currently putting in manually because we cannot offer a connection, and that is like absurd, frankly. Healthy Connections and the Rio. So there's a lot of really good opportunities here for interoperability, for connectivity. And if you think, you know, I keep giving an example of like, if you have somebody who's perhaps released from the BSU unit at CMC, you know, and they are a client at Whole Health, our clinician could potentially, with the right interoperability, could see the notes and the records for that person who's showing up for an appointment the same day that they're released, right? So that is kind of, and same thing, if someone's admitted to the hospital, they would have the opportunity potentially to go look and see what medications that person's on, any notes from their clients, of course, all with the appropriate release of information, et cetera, et cetera. Access to data modeling, dashboards, and population health analysis. You know, I think it is important to me to be data-driven in our decisions and our resources, right? We are in a resource-scarce environment, and so we need to be making the best decisions with what we know is having an impact. And it's a little hard for me right now to tell you what's having an impact because I can't pull any of the data from the work that we are doing to evaluate it. And then lastly, I added sort of the ability to bill for the PROS program. Our PROS, Personalized Recovery Oriented Services program, is a little bit unique. It's also an OMH program, but the billing is sort of specialized. So again, we've also hit a wall with some other providers that can't offer us the ability to do the billing for PROS. So it has to be a system that can offer that billing. So those are a couple of the things that you will see in an RFP that will go out at some point in the near future. And then I wanted to touch a little bit on implementation supports, because I think this is something that, you know, what I didn't share in these slides is this is either the third or fourth EHR implementation for Whole Health in the last however many years. And I think part of the problem there is that you know, if you end up with sometimes the cheapest, it is not necessarily the most lasting. So you continually kind of have to do this over and over again. But that does mean that we have learned a lot around implementation. And I think, you know, as unfortunate as it is that we're doing this again, it is really important to note that we have several folks at leadership right now at Whole Health who are a part of the last implementation. And so I want to do this while they are still there so that they can support us in this process and really bring their expertise. So just a couple of things that we would really sort of make sure we focus on are, you know, developing and executing a comprehensive implementation plan around workflow analysis, data migration, system configuration, testing, providing role-based training for all staff, really supporting and identifying departmental super users who can really serve as on-site resources before, during, and after implementation, communicating really proactively with clients regarding implementation, including timelines, really doing a lot of support and training around patient portal enrollment and the use of new digital tools. I think this is really important to us. Would really spend a lot of time on this. We want this to be something that can be used by everybody. Utilizing a phased deployment as appropriate, comprehensive testing, contingency planning, and really making sure we can have sort of a continuity of operations plan during this time. And then supporting long-term success by sort of ongoing system optimization, refreshing trainings, workflow refinements, and performance monitoring to really maximize the benefits. So I thought those were important to touch on, since I know that the EHR as a topic du jour in our community can be top of mind for many. So I wanted to kind of highlight at least what we've already been thinking about that we would really put in to make sure this is a success. Questions and discussion?
Well, I guess I'll start. As I was listening, I was thinking about myself as somebody who has congestive heart failure. I go see Guthrie for this, I see Centralis for this person for that. And I just was thinking to myself, oh my God, what would I do without my patient portal? The medications and appointments, and I do a blood test and I get the results in my email. I can go and check everything. And then I can research for the next 3 hours to see what's wrong with me and what's gonna happen to me. but my doctors can all easily communicate with each other, which makes my health much better, and it's allowed for me to have improvements that I wouldn't have been able to have before some of this technology existed. So I just can't imagine being a patient and not being able to do that. A few years ago, we switched our billing system, and we captured 3 times the amount of registration fees with this new system. And every 2 years now, we look at new systems. Some cost more money, some are less, but technology is constantly changing, trying to keep up with caregivers and their needs. So I definitely can understand why we're here. I guess the big question would be, there's going to be some cost associated with this, and at the end of the day, whatever that cost ends up being, are we able to capture some of that cost on the back end with people having to do less work, less redundancy? I know it won't happen in the first year or two, it may not happen in the first few years, but whatever the initial investment is, outside of what it does for patients, which are the most important folks, are we able to look at ways that it'll pay for itself to some extent? That would, and you don't have to answer that today. I know we're going to come back at some point with a resolution, but that would be, I guess, the big question for me, as outside of knowing that it's probably time for a change, whatever the cost is, are we able to mitigate some of that? Because it causes people to have to do less and take less time doing things.
Yeah, it's a great question. I mean, the answer is absolutely yes. We're looking at that, and I can give one example right now. I think a good one is the no-show rate, right? Like we have a, I guess I actually don't have a great comparison for other counties, but I would say like we have a no-show rate of folks who just don't show up to appointments, and some of that could be that like they know they can't make it, but it's kind of awkward to make the call, or you don't want to make the call, or you think of it like at 9 p.m. after you've done all of your other chores for the day and think, oh shoot, I really need to reschedule this appointment, and like the only way for them to do that is to call us. So having the patient portal, I think that we will see a reduction in our no-show rate, and so that's just one small example, but there's a lot of others around the billing, the prior auths, records, and things like that as well. So we're certainly looking at that.
That prior authorization is like a nightmare for me with my medications. Oh my God, having to deal with that. So I can only imagine not having a portal, not having all this stuff on the updated, how difficult that would be. Other questions? Cindy? That's Cindy.
It's okay. No, people call me.
No.
I get called like Cindy Bronk more than I get called Christy Bianconi. It's too funny. But I mean, I think a few things. I want to say kind of really going through the report in more detail and seeing very clearly what's happened with this company. It started off being like a really good partner for us, and that's why so many people went with them in New York State, and then seeing how those multiple acquisitions have really watered them down. It's not a question of, like they're losing their capability. We need a new EHR, and I think we would rather do it proactively than wait for that system to go completely unserviced and then have to do a panic migration. That's not good for anybody. So I really do appreciate the forethought that's going into this and looking at the big picture and thinking about the alternatives that are going to make it so we don't have to keep going through this over and over again. So thank you for that. That being said, is there any state money that could help pay for this?
I've been exploring it. I think kind of unfortunately we missed the wave of a lot of sort of the New York State like data integration funds. Also, unfortunately, for example, the Rural Health Transformation Grant was just released, and it includes, like, you could use that funding for an EHR if you don't already have an EHR that meets a certain threshold, and ours does, even though it's not great. So I think I've really been exploring that. I've investigated through Anna Kellis's office. We weren't able to turn anything up there. So I think the answer is we haven't come up with anything, but we are in pursuit of that. And I'm trying to leave no stone uncovered. And we have also done some outreach to neighboring counties to understand if there's an opportunity to do something collaboratively that would potentially cut costs. And so Corsa and I have some emails out to folks and have been hearing about other approaches that they're doing as well. So I think it is very much my motivation to try and do this with the least amount of county funding as possible, although I have not yet been successful in kind of turning anything up to support this. Yep. And thank you. I really appreciate you sort of sharing that and echoing that experience, because that has also really been our experience. And many other counties have 10, 11 and are, also heading to the exit doors. So we are not alone.
Rachel?
Thank you for that presentation. I agree, it makes sense to get a new electronic health record. I'm curious, this kind of builds off your comment about maybe working with other counties, but I'm curious if there's any opportunity for like collective purchasing of a license or something. I know that, you mentioned MyChart. I know Centralis uses MyChart. I don't know if Guthrie does, but it would make sense if the like major health providers in a county all used the same system so that it was easy for patients to kind of have all their information in one place.
Yeah, absolutely. I agree. I mean, the way that we will do this is we'll put out an RFP, and it would be great if we see a response also from the more local provider. I think because of the fact that Centralis recently transitioned to Epic, it has opened the door to make that a possibility. I think counties like us cannot necessarily get into Epic on our own, but because Centralis has done that, that is now, it is a possibility, and we'll see after we issue our RFP kind of who we get back and what looks like makes the most sense.
Oh, so Centralis could respond to the RFP.
Yeah, they have an arrangement with a partner that has been doing their EHR implementation and sort of holds their instance of Epic, I have learned. So that is one partner that, that organization, Extensis, could respond to our RFP.
Okay, thank you.
Other questions? Veronica?
I guess not a question, but I totally support this move. It sounds like the current software is, however good it was previously, it's helpful to hear, is not like up to standards now. I know just as a patient, it's such a big difference to be able to sign things. And I'm not a patient at Whole Health at the moment, but to be able to sign things electronically, like it can be a whole major, like multiple errands just to sign a form if you can't do that, which is a pain. I also, the bit about clients not being called by the correct name or pronouns sticks out to me because that's important. And I know like queer people and trans folks especially are constantly asking for recommendations of like, where is a like trans friendly place? And if someone got dead named at Whole Health, they're gonna say, well, I got dead named at Whole Health, don't go there. And people talk all the time.
Yeah, and that's not the care that we want to be providing, just to make very clear. Yep.
Any other questions? Jenny, did you want to do any sharing about Whole Health in general while you're up here?
No, I feel like you've heard on two important things today, so I'll kind of leave you with that for the moment. A little Heath air quality advisory today, but we got that out in a press release. Looks like it's not getting better tomorrow, but that's, yeah. Of course, so do you have anything you want to add on the EHR piece? We've talked about it quite a bit.
Just the good news part, it can be anything from a couple of 100,000 to a couple of million, depending on where we land. And as Jenny indicated, there's one county that right now they are beginning the process, and they're looking at a collaborative effort with the hospital as well as a care home, and going in together. So we're trying to explore all options to make sure we get the best product. As Chris indicated, 1011 was it then, now it's not. And it's not just a feeling that we have, it's across the state. And there's another product that other counties are also struggling with and trying to move away. And when I sent a message out yesterday, I received several messages from other counties that in the same boat as what we are doing right now. The idea of multi-county approach has not yet been really tackled, but we will do whatever we can to make sure we get the best product in place. But that being said, yes, I agree 100%. EHR right now is outdated, and we need to move in one direction or the other, and we need to move quickly. So we will continue to explore what options we have, how we're going to pay for it, what is available, and make sure we make the right decision, not just financially, but customer engagement, workflow services, employee engagement, all those pieces are critical value. So just to indicate, when we RFP, we are just not looking for the cheapest product, but we are looking for the best. And not just affordability, but effectiveness and efficiency, all those mechanisms. So we're keeping our eyes on the road. We are hoping that, if not the fourth quarter of this year, but that's the goal, to be able to RFP out fourth quarter and see what options are available so that we can start a process in 2027. So don't be surprised to see a number in the budget as maybe initial step towards those implementation process.
A quick question. So is this something we would do as like a capital fund project? Is that how we would pay for it?
I'm speaking with IT and all of that, but it could be. We can decide to borrow for that, or we can decide to fund it with internal resources and determine the payment plan and all of that. So there is multiple options we can explore on how to meet the cost of the service. So the RFP side is identifying the product. How to pay for it is what we will have sleepless nights over.
Sure. Thanks.
This is a big question, and you could just say you'll think about it, you'll look into it and answer later. I would imagine that almost every medical place, from Reach to your family doctor, uses some sort of billing system, right? Listening to different folks over the last few years talk about the systems not being able to talk to each other and the difficulties in sharing information, is it possible that there's a system that's bought for the county and different offices, different providers can opt in at a cost into that same system to alleviate some of those barriers and to bring the cost down for everybody? I don't know if that makes sense, but yeah. I know talking to, I forgot who it was and where they were from, well, one of the frustrating things for them was that they have patients that use different providers for different needs, but they can't communicate with each other, and then it slows everything down. So what if we had a system that everybody could opt into and be able to share information, but everybody would pay their percentage of the cost?
That's what we're trying to explore. And there's also state law and other things that guiding data protection and other pieces. So we're just making sure we are making the right decision. So if we identify a product that we believe could potentially serve a greater good by making it available to other entities, I think we will make sure we touch every stone, as Jenny indicated, to make sure we're making a broader collective decision for the community.
Cool. Thank you. Any other questions? Thank you, Jenny.
Thank you all.
And since you got the mic in your hand, you might as well pull it right back and do your update, your report.
I don't have a lot to go through today. We had some few issues we're dealing with earlier. Things are quiet now. I don't know if Brittany is here or she'll be joining online. We've been meeting about the social services advisory board process, and when it gets to DSS, we can discuss that aspect on where we are. But we are working on putting things together for all of you, and I think we have a framework that we can move forward with.
Oh, DSS is next.
Are they here yet?
I haven't seen.
Yes. So yes, we don't have DSS on, so probably can move to other departments to see if Brittany or the team can join us later.
Okay. Cindy from the Human Service Coalition, do you want to go? I know that Kate had sent me an email earlier. Teresa's celebration was today, so I know Kate has joined in via Zoom, but she didn't have a lot to share, so we'll go with Cindy.
Hi, good afternoon. I have just one quick piece of information. The Human Services Coalition is working in partnership with the Health Foundation of Western and Central New York and a couple of other regional community organizations, and we're hosting an education and planning event for the forthcoming Medicaid changes. As many of you know, the Big Beautiful Bill, or HR 1, has proposed many changes to the Medicaid program, including expanded work requirements and expanded requirements around enrollment and more frequent enrollment. And it's going to be pretty significant impact on communities. In New York State alone, they're estimating like 1 million people could lose their Medicaid coverage because of the new requirements. So the event, which is taking place on July 28th on Tuesday, it's an all-day event in Syracuse at Drumlin's, which is like this conference center place. We are going to have a session where we're going to be kind of level setting the communities around the requirements, and then actually having planning sessions by county in the afternoon. So anybody who is interested or serves Medicaid clients or could be impacted by the changes is welcome to come to this convening. The more the better. Policymakers will be amazing because there will be impacts. So we really want to get ahead of our planning. Brittany and I have been in contact and communication. What we'd like to do going forward is to adopt a similar model that we did with the SNAP changes, really working together as a community and coming together collaboratively to ensure that we are doing our best together to try to mitigate these impacts in Tompkins County. So if any of you want, I'm happy to send the information directly to you. I think I sent it to Travis and a couple of other folks, but I'm happy to send it to the whole group if you'd like it.
Thank you. Any questions for Cindy? All right. So,
this is Veronica. Can you send me the info too?
I sure can. I'll send it to the whole HHS committee.
All right. Thank you, Cindy. Was there anything else?
No, that's all today.
All right. Up next, we have Tompkins Community Action and COC, Liddy and Danielle, who are our guests this afternoon. Brenda Westfall was unable to join us. Brenda's the director of IHA. The idea was to have a conversation about housing and some of the impacts to programs that we wouldn't know about, otherwise see, and then what are those long-term impacts? So, for example, I was having a meeting with Brenda, and she was telling me that they had 75 to 100 less folks on Section 8, and there's 2 different programs in this community, maybe more, but I know of 2, than they did in the year past, and she expected to have much less in the following year, and is concerned that the program may not exist by the end of this current administration's term. Part of the problem with that was when folks are off of when they lose their benefits, then what happens? Things were already unaffordable, and then what happens now? And then the wait list, I think she said it was 4 years at best. So she was unable to be here. Danielle was able to be here. So I will turn the floor over to Danielle and Liddy, and then we'll just have a conversation.
Right, thanks. So yes, like Travis said, there's 2 Section 8 programs in Tompkins County, Ithaca Housing Authority and Tompkins Community Action. We've had our programs since early in the 1980s, but like the Ithaca Housing Authority, we have lost about 95 vouchers in the last 2 years. Our program is directly under New York State Homes and Community Renewal. So the state tells us what our voucher allocation is, and then we do our best work to use all the vouchers they give us. And so we're different in that aspect because Brenda at IHA has her pool of money and spends it appropriately based on their operations. So we're a little bit under the mercy of HCR, and they suspended our voucher issuance in February of 2024. This is the longest suspension we've ever had. We don't know when it will be lifted. They at HCR have suggested possibly early 2027. So we still have at least 2026 to get through. The positive thing that I could add is that under HCR, Tompkins Community Action is a high performer for audits, which puts us in a good position to be, have the suspension lifted, have vouchers given back more quickly than a struggling county. But in addition to not having vouchers to issue, our waiting list is closed to new applicants. We had to close our waiting list in September of 2025 because the wait time had extended past 5 years. So anybody who's on the waiting list, remained on the waiting list, can continue to update their address, their information, and when we are able to open the waiting list again, we'll make public announcements and start based with who was on the list at the time that it closed.
Danielle,
yeah.
If we have questions, would you like us to ask why you're going or wait?
No, well, we're going, it's fine.
Can you, so when you say we have 95 less, that means that the state said, the state has given you 95 less, not that you can't find 95 more people?
Correct. There's way more need than the vouchers that we have. We lose through regular program actions about 5 vouchers a month, and we're not allowed to issue new vouchers to replace them. So every voucher we lose is lost to the community, and we may or may not get it back. So looking at those numbers, it also makes us look at staffing levels and how we're going to do things in the long run. But what we're here to talk about today is the impact of those lost vouchers and what it means when people need rental assistance to be able to afford the rents. What happens when there's no assistance for them? What happens when you can't afford your rent anymore and you go through eviction court and then you lose your housing, you're in the homeless emergency response system, and you may never have experienced that before. That is one of the things. What we are doing, we've always been as flexible as possible with the regulations that we're provided with. So when I say we're losing 5 vouchers a month, those are vouchers with households who have passed away, who have moved out of the county, and the office they're going to absorbs them, so it becomes part of their program and not ours. We don't have a lot of program violations or people not recertifying. Those are not the ways that we're losing the vouchers. So we're being very mindful of that. One of the questions that we had was how and if we're still doing rent increases for owners. And right now, HCR is allowing that. Reasonable rent increases, still have to fall under the fair market rent and the payment standards and be appropriate. But those can still happen. There are funding streams that allow security deposits to be offered through the Section 8 program. That is still in place. So it could get worse, I guess is what I'm saying. Let's see, I'm just looking. The only other bright spot I have about the voucher program is that this year we participated in the Housing Access Voucher Pilot Program, which is a parallel program to the voucher program. It's mirrored after it, but it's not an actual voucher. That pilot program serves people in the homeless system. So DSS sends us referrals and we do the work to help them find the housing and pay for the housing once they get in it. That's a 4-year pilot, and there are 14 of those vouchers in Tompkins County. 6 have found places and are living inside, and then there are 8 additional vouchers still searching for the housing. those are my bleak highlights. Lots of questions, whatever questions you've got.
So the idea was to, well, we a lot of times, this committee is new having housing back. It was in HED for a few years. And so the idea is to make sure that the legislators in this committee know the different programs that exist, what's happening with them, and then at the end of the day, through different mechanisms, try to figure out solutions so that when we have folks that are on Section 8, eventually, if they lose it, could end up houseless, right? And then we have a different problem, and we have a more expensive problem. So not today, but over a period of the next few months, in listening to folks come and present, the next step would be, what is it that we could do as a county differently to help build up front so that things are less expensive at the end? And so if y'all have any questions for Danielle, now would be the time to ask. Rachel.
Thank you for coming in. I was wondering if either of you could talk about the idea of a county-based universal housing voucher program. I understand that that would be expensive for the county, but I would imagine it would actually be less expensive and less traumatic overall for everyone involved.
This is one of Libby's favorite
It's
things.
very hard for me to pass up an opportunity to talk about universal housing vouchers, but I didn't come with a brain full of information about them necessarily today. What I would say is the HCV program is primarily benefiting people who are making at or below 30% area median income. So I hear you say universal, but what I might say is targeted in some ways if we're really trying to like match that to the income levels. So it's not universal, it's universally available to people in that area median income. And just as like a fun fact, because I wrote it down. So the housing rate, National Low Income Housing Council calculates the amount of money a person needs to make in any given community in order to afford a 2-bedroom apartment. So the housing rate that was calculated for Tompkins County is $32.70 an hour. So I think there's universal housing vouchers as an option, and I also think that there are options around wages or how we're thinking about wages, or some balance of both of those things that could help stabilize this large and growing section of our community who's currently relying on housing vouchers. Also, 1 in 4 people nationally who qualify for a housing choice voucher already don't have one. So we're already like way behind. I don't know what our number is of like how many people would qualify versus how many people have them, but I would think it's something like 0.5% of people who qualify and could use one. So certainly anything we can do as a county to expand housing access. We're on a slippery slope.
And you wouldn't have any idea the actual number of folks wanting vouchers because you don't even have a wait list anymore, right?
Right. Our waiting list was already over 1,000 applicants before we closed it. And we had just done what they call a waitlist purge, which means we've reached out to everybody and people responded. So it's not like we have a 5-year-old waiting list and all those people have moved on. It's pretty accurate for what we have. And the other thing to keep in mind is our voucher suspension is based on a New York State Homes and Community Renewal budgeting stuff. It has nothing to do with the changes proposed to the Section 8 program at the federal level. So all of that still could trickle down and, explode the issues that we're already looking at.
I know in talking to Brenda, their program is a national program because it's from HUD. Yep. And so people that live in the county, if they wanted to move to Atlanta, Georgia, would take their Section 8 with them and they could go. And that would be one less voucher now in New York or in Tompkins County. And so that's one of the ways that the numbers go down is when people leave the area, we have less vouchers here in the area. Christy?
Yeah, I'm pretty sure you can do that through TCA. It's called portability, right? Which is just fun fact because I used to work. Danielle used to be my boss. She was the best boss ever.
But if you move, if you're on TCA and you move, that county now picks you up, right? Or
County decides. If they move within New York State and it's an HCR county, they'll absorb that. But wherever they go in the country gets to decide, like, yes, we'll take you, or we'll take you, but we're going to have TC Action pay for it.
Okay.
Yeah, and it's really sobering. I think a few things when you look at this and you realize just how much the federal government is passing down to the local communities. It's we can't make up for millions of dollars. And I think you opening this up and us thinking about, well, what can we do as a community to be resilient, and what kind of housing projects can we try to get started here and keep the pipeline strong? One of the things I was thinking about, I thought I would ask is, for TCA specifically, how is the relationship with the landlords going? Because what makes Section 8 so unique is that it's the landlord has to, it's not public housing, right? The landlord has to agree to it. Mm-hmm. And if they won't take a voucher, then that voucher kind of just sits there. So how's that climate?
Yes, we are seeing landlords become more flexible and more interested because there are less and less community folks who can afford the rents. The fair market rents, I can't remember these numbers ananymore because they're so.
Is it $11.90?
For a one bedroom, it's $1,466. That's just a one bedroom.
1,400?
Yeah. Yeah. That's mind blowing. And then, the utility allowance charts that are used to factor in are very low, and they don't, the allowance that the program provides you is not your same as your bill from NYSEG. It's several $100s different.
So that's $1,400, not including NYSEG.
Yes, the fair market rent will have the rent, all of the housing costs.
Okay.
Yeah.
I think another consideration, I just want to say this, I'm sorry. I came with things to say about the loss of the HCV vouchers is a lot of times when we're planning and thinking and doing the on-paper work, in fact, I heard a really great conversation about this earlier. We want to think about transitional spaces or in-between spaces, but until there's a new system, currently those are all bridging, generally bridging into long-term stability using a housing choice voucher as the economic source of rental assistance for that client. Once, in this system where you're thinking about somebody's going to go to treatment, halfway house, transitional housing, and then move into the community, unless there's a huge employment goal set for that person, that the way that it's mapped on paper right now includes that HCV voucher. So somebody's going to be getting through all of those, supported or supportive environments, and then not have that bridge into an HCV voucher lasts as long as you need it to, and it flexes with your income. So you get more income, you end up paying more for your rent. You lose a job, you don't lose your housing, you just are paying less for your rent. But we're losing the other end of the bridge, so we're going to end up with kind of like a bridge to nowhere when we, at a big scale.
Veronica?
I don't remember. If someone has a housing choice voucher and moves to Tompkins County, then what happens then? If we have no additional vouchers, do we just say you can't?
Yeah, no, they bring their voucher. They bring it. So what Tompkins Community Action does right now is we have that housing authority that they're coming from. We bill them, but they become part of our program. But they don't count towards our utilization because the other county or state is still paying for them. So it doesn't prevent them from coming here, but it doesn't add numbers to our program.
Okay. Another question, what difficulties, if any, are you seeing with people who do have Section 8 vouchers in finding housing to use them on?
I think right now people are scared to even try to move. I think that when you have a voucher and you're looking for a place, it's a limited amount of time, and if things go poorly and your time runs out, it's very hard to maintain that. So I think a lot of folks on our program are staying where they are, even if it's not the best or most ideal situation for them. And I can't speak to how easy it is for people new vouchers finding. Maybe Brenda, I think they are issuing some small vouchers. I have no idea how long the search time is. Before our suspension, people were needing almost the full 120 days to locate housing and extend after that if possible.
Christy?
Yeah, I think this is interesting to think about too from like a legislative perspective and a policy perspective, and it goes back to what Liddy was saying. What makes Section 8 HCVP so unique and I think successful is that it is such a versatile program, and the person gains that benefit, they can use that benefit unless their income prices them out, but they get a grace period. But if they lose income, you know, the program flexes to them. And I think what the federal government was trying to do was move to this block grant system. Is that right? They wanted to get rid of vouchers altogether and just give the block grants. And I think that that's something we need to think about from like a legislative perspective. And I'd love to hear your opinions. We don't want that, right? We don't want block grants. And it'd be good to hear your thoughts about why not.
Right, and also the time limits that they want to put on the Section 8 vouchers, completely unrealistic. We heard what the housing wage is, and we know that that's not something that's possible for many here, which is why we have such a waiting list demand. So yeah, having it go to the block grant. I mean, as not ideal as it is to be housed under the HCR right now, it does put us in a position where we are able to grow the program in normal times. If other communities, other counties in New York State weren't using their vouchers, HCR would call us up and say, Danielle, I'm going to give you 25 vouchers. Can you lease them up in the next 60 days? And we would say, yes, done. And that's how we would grow our program. I would like to get back to that kind of stress.
Other questions? I would imagine that at some point over the next 2 months, I would say by September, we'll be at a place where we'll be looking to put together some sort of housing working group. I love working groups. So while you two are sitting here, if we put one together, would you two be interested in being on that group? Well, Liddy, you don't have a choice.
Liddy doesn't have a choice. I'll be there if Liddy's there. We're tag team this for decades now.
Yeah, we're at it. We're in it.
All right, thank you. I'm glad you all were able to come in. I really want to open this door up so people really see what's going on behind the scenes and how Section 8, vouchers from DS, how all these things affect houselessness and these decisions that are being made in New York State, in the federal government, how that affects counties, so that we can really sit down and understand it well enough to figure out what we can do as a county to offset it. I was talking to somebody the other day, and this is not an idea that I'm going to suggest right now, but if the county put $100,000 toward, what do you call those things? When you rent an apartment, you have your rent and your security deposit. How many more people would be able to get into housing? And if more people are into permanent long-term housing, what effect does that have on the shelter system? We're spending up, what is it, $139 or $149 a night? So I think that we have to be as creative and nimble as possible, and there's not 1 or 2 or 5 solutions. There's probably 45 solutions because you have people with different needs in different pockets. So thank you for coming and starting this conversation.
I just have one last question. I'm curious, is there a fund for folks who are like, back rent, like a one-time use fund for people?
There is different funds throughout the community. There's the Robin Fund at GAC. Catholic Charities has a fund, and there may be more, but I know there's 2.
Primary sources right now for people to access assistance for rental arrears is the DSS, you know, entitlement temporary assistance stuff, or the 1115A waiver, and other than that, it is very slim pickings.
Where do people go to get the 1115A waiver?
Oh, there's a variety of ways.
Okay.
They could call 211 to
Gotcha.
find
Okay.
out more, but lots of organizations are involved. There's a lot of places to get screened and get connected.
Okay.
And that can help with up to 6 months of rental arrears for people who are eligible and have a need.
Good to know. Thank you.
Mike?
I just wanted to throw out an observation just because you brought up the $100,000. Just from my experience, it's not even that. It's a matter of how quickly THA and Ithaca Housing Authority act upon a lead when it comes to housing. Like you had a woman, Tia, I think. Like I posted an apartment, she called me. I mean, we had the whole thing done probably in 6 hours. And the reason that's important is because she's competing with everybody else. Like, I post an apartment, it gets calls. I mean, you might get 10 calls. And I got to take first money in the door. Otherwise, I can explain that to somebody. I can say, listen, they gave me the security deposit first. And the fact was, Tia was just on it. And that's why that apartment went to who it did. It wasn't a matter of it being Section 8, not Section 8, whatever. It was just first money in the door. And she was just really quick with it. And I mean, that's just my 2 cents on it. She doesn't work for you guys anymore, but she was really good. But,
Great, yes, yes.
So anyway, it really is something as simple as that. And why do certain people, like now I can see problems. Like I have one family and they were a growing family actually, and they've kind of outgrown the apartment. It would be nice if something else was available to them. And I just don't know how that works within the system either. Like, now I have 3 kids instead of 4, so you got somebody living in the living room. And that's not really optimal, really. I mean, you want people to have some space. Then again, where is that space?
Right.
I don't know where that is. So, not with me, but it's with somebody. I suppose. Anyway, just throwing that out there.
All right, thank you. We have some guests from the Food Bank of the Southern Tier. Come on up.
Hello. There it goes. Hi.
How you doing?
Afternoon. I'm Randy Quackenbush. I'm the Chief of Staff at the Food Bank of the Southern Tier. I've been at the Food Bank for about 13 years and Tompkins County resident. I'm here filling in for Sarah DeFrank, who's our Director of Advocacy. And do I have a time crunch? Am I the last thing before adjournment?
20 minutes.
20 minutes, perfecto, okay. Yeah, so gonna talk briefly about the food bank. I know several of you are pretty familiar with the food bank. Providing an update on current statistics. Want to talk a bit about the value that the food bank programs and partnerships bring into the county, and then a little bit of the lay of the land. First, I just wanted to thank the county. I actually went into our database and we've received over $1 million from Tompkins County since '97, and that is actually funding that has gone directly to our network of food pantries. I'd say the majority of that funding has probably come in the past 10 years, so that is tremendous. We actually only get funding from 3 of our 6 counties, and Tompkins is a leader in this area. Not surprising. And really, this has been in partnership with the Human Services Coalition. I see that Cindy was on the call. They help manage our ask through to the county. So just briefly a little bit about the food bank itself. Our mission is working together to build and sustain hunger-free communities throughout the Southern Tier, and we really are committed to this vision of a future without hunger. We don't want the food bank to exist. Unfortunately, our services and our pounds and people served have continued to grow, but ultimately we would not be an entity at all, and that's really our true vision. We are one of 10 food banks in the Feeding New York State network. We collaborate on a variety of areas around food sourcing, advocacy, and marketing, things like that. You can see we're a pretty relatively small food bank compared to some of the other ones. We cover about 4,000 square miles versus regional food bank going all the way to Canada down towards the city. so a much smaller footprint. We are also a part of the Feeding America network, so we are one of over about 200 food banks across the country. This enables us to tap into donors, egg donors, retail donors. Feeding America owns the relationship with businesses like Walmart, those national donors, so we are able to collaborate and recover a lot of retail food through this network. Just a little bit about our own service area. Again, those 6 counties, Steuben, Schuyler, Chemung, Tompkins, Tioga, and Broome. Our facility is in Horsehead, so about 45 minutes from here, but we cover all of these 6 counties. In our county, or in our service area, we have 77,000 food insecure people. That's around 12% of the population. And we know that to meet that need, we would need about 14.5 million meals. Another sobering statistic is obviously child food insecurity. That's about 20% of children in our service area being food insecure. Last year, we had 1.76 million requests for food, and of that, almost 600,000 were from children. So where does this food come from? This is a question we get quite often, and I'm going to refer back to these 3 buckets a few times. The biggest one is through the USDA, called the Emergency Food Assistance Program. This is also known as TFAP. You might remember the government cheese from back in the day. This is the modern version of the government cheese program. We, in the first Trump administration, we actually got a large amount of TFAP because of all the trade mitigation, the trade wars with China. We saw a big bump of TFAP kind of during COVID, and then over the past few years, we've seen decreases in TFAP, and we've also seen cuts to certain loads through USDA, especially at the beginning of the administration last year. Typically, we try to get about 1/3 of our food from each of these buckets, and we're getting about 10 to 15% of our food through USDA now. So a big, big dip. One thing about TFAP is that it comes 100% free to food banks. Sometimes we have to help pay for some of the transport costs, but we get that food for free, and then our network is able to access that food for free. Our second bucket is donations. So typically when you think of food banks, you think of donated food. So we get that again, like for those national donors, Wegmans, but also smaller like food drives. But the bulk of that comes through retailers. And then finally, the third bucket is wholesale. So we actually do purchase food. Often, most of that food is covered by a variety of grants, including the grants that we get from Tompkins County. So those are 3 buckets. So just a little bit specifically about Tompkins. You're probably familiar with these statistics. About 1 in 8 residents in Tompkins County are food insecure, and that includes 1 in 7 children. So it's 13,000 people we're talking about. I remember back in the day with Kirby Edmonds and like talking about how do we actually reach all of these people. And I remember that being like his big vision. Like this is actually like a solvable number. It's not that many people that we're talking about. But we're still facing these high levels here in Tompkins. Some charts just to show you our requests for foods and kind of the trends. So this is through our pantries, our mobile food pantries, and our meal sites. So you can see pretty clearly from 2019 to 2025 where we are. We did see this dip in 21 and 22 as we had the COVID response, as folks were getting max SNAP benefits. All the programs that were in place, it was some of the best anti-poverty work I think we've ever done as a nation that was successful and worked. And then we saw a lot of that roll back, and we instantly saw an increase at our network of pantries. As I'm sure you're aware, folks lose benefits. Food is the one place in our budget that we have wiggle room. So if times get tough, if your NYSEG bill goes up, people turn to the emergency food network. This chart just breaks up by pantries, meal sites, and mobiles. I think a huge story here in Tompkins County is that the bulk of our food is moved through our network of agencies. So folks like TCA, GIAC, and many partners, they're the ones doing the work on the ground. So we partner with organizations, we sign a contract, and they're able to access our food menu. So the bulk going out through pantries, a little bit going out through our mobiles, and then meal sites are also in here, including Loaves and Fishes. So just a little bit about the individual impacts of these agencies here in Tompkins County, which is where the funding from the county goes to. This is some newer data that we've actually just started crunching in the past few years, where this is straight food and some non-food. What is the value of what the food bank delivers through our network in Tompkins County? And it's about $4.5 million, mostly food, but a little bit of non-food, equipment support and things like that. So this is gonna get a little wonky, and forgive me if this is a little bit in the weeds on some numbers, and hopefully I will make sense. But the majority of that $4.5 million is actually going through our pantries, as I mentioned. So they do the bulk of the work on the ground. And the pantries themselves, they access our menu, but sometimes they do have to use their own discretionary money to purchase food if they spend beyond what the grants are providing for them. So out of that $4.25 million, agencies and partners, they had to spend out of their own money about $400,000. And that breaks down to about 13 cents a pound, which is actually a really good number. And who are all these agencies? Here's my list. Travis obviously is very familiar with GIAC, but we are pretty geographically covered in this county. Obviously, most services are here in Ithaca, but pretty much every small community does have an agency. I think we have some of the most innovative agencies here in Tompkins. Again, I think Loaves and Fishes is one of the best meal sites in our service area, even in the state. Innovative programs like REACH that we started partnering with last year, No Mas Lagrimas. Enfield is one of the biggest pantries in our service area. Everybody's pretty familiar with the Enfield Food Pantry. So these are the folks who actually do the bulk of the work on the ground, moving the food. So just to get a bit more wonky, this is the 3 buckets that I talked about. So this is what came into Tompkins County last year. We had about $500,000 of TFAP come in, and that again cost $0 to the agencies. We had about $2 million of the donated retail food. And the agencies do pay a small shared maintenance, and that's to cover our gas and our trucks and to deliver it to the agencies. That costs $23,000. But then we also purchased $1.7 million of retail or of wholesale food. Excuse me. If we hadn't had grants, we would have to pass that cost on to our partners. So they would be looking at $1.7 million in wholesale food. This is when I'm gonna get really in the weeds. But thankfully, we have a variety of grants that we actually pass through the agencies to cover the food. So we get state funding through Department of Health. We have Nourish New York funding. And then we get $200,000 last year from Tompkins County. So out of that $1.7 million of costs of wholesale, we cover that with these grants. So that's how we get to that. The agencies picking up the rest of that $400,000. We always encourage our agencies to fundraise, to have their own bank accounts to ensure that they have discretionary money because grants are volatile. We don't always know how much we're going to be able to cover. Then just briefly, I'll talk about our programs. So these are what we administer through the food bank, and this is a much smaller footprint here in Tompkins than in other counties. So that the value of that food is about $250,000. And that is totally free to our program partners because it's our food that they just help us to distribute. So some examples of our programs, our school food center program, which the county has funded, I think, the past 3 years. That's a photo of, it's actually my friend Rachel. She's at the Ithaca High School. If you would like to get out and visit one of these sites, I think, Rachel, you might be going to one soon, or am I misremembering what Sarah said?
Yes, we had plans that I would go to some, but we don't have a date yet.
So I'd encourage you, if you ever want to get out and come visit one of these sites, especially because the county has been financially supporting the schools. We have 2 in the Ithaca School District and Enfield at the high school. There's a really amazing program up in Dryden. They were actually kind of one of our pilots. And then a really cool program out at TST Bosie's, the bodega. We also have a couple kids farmers market sites. So these are where we hand out free produce. We have our backpack program in 11 of the school districts. And then we have 1 mobile food pantry in Tompkins up in Freeville. And then we have 4 senior mobile food pantries. So again, the value of the food through these is about $250,000. So just to round it back, that's the imprint, the food in kind, about $4.5 million, and knowing that Tompkins County funded $200,000 of that for wholesale. Did that make sense? This is actually the first time I've walked through this because I'm filling in for Sarah, so hopefully it made sense. This slide just shows the blue is how most of the food goes out through agencies. So this was requests for food from last year. We did do over 3 million pounds here in Tompkins County. A big priority for us is fresh produce. So we're really proud of about a quarter of our distribution being fresh produce. Just the final piece, what's going on? You're hearing this from everybody, federal cuts trickling down to the state, trickling down to us, right? The HR1, which Cindy was talking about on the screen earlier, the changes to SNAP, we're starting to see the impacts. The expanded work reporting requirements went into effect in July. My coworker Sarah worked really closely in the county in trying to get folks to be able to meet work requirements and reporting requirements, but we know there's a significant risk of SNAP dollars, of people losing access to SNAP and those dollars not being spent here locally. SNAP has an economic multiplier, so every dollar of SNAP that is distributed, it actually generates about $1.60 to $1.70 that you're spending at grocery stores, that pays cashiers, that helps businesses stay open. So we're worried about, obviously, the economic impact, but also the impact of people just not having access to SNAP. You're probably familiar with the increased work requirements, but now more people are impacted. And I like to call them work reporting requirements because it's so onerous and it's a lot of what Medicaid participants are gonna have to deal with. I don't know if we have current stats in Tompkins of how many people are impacted. I think it was a couple, maybe about like 700, but don't quote me on that, of individuals, but I will have to double check. But yeah, and also asylum seekers and refugees no longer have access to SNAP as they historically have. So good times. Some other kind of trends, as I talked about those 3 buckets of food, as we're forecasting, we're looking to see less TFAP from USDA. Kind of coming out of COVID, we've seen a decrease in retail donations. Donors and grocery stores have gotten really good at like reducing their shrink. They're not donating as much across the country just because they're managing their costs. So what we've been doing is this more wholesale purchasing, which isn't a sustainable model. When you think about food banking, you think about donated food, right? So we're actually buying food and getting grants to cover it, and then getting that to the agencies. So we're doing a lot of work to think about how to address that. We obviously do a lot of advocacy on the federal level, but that can only get you so far. And we don't have a lot of manufacturers in our service area compared to our colleagues in Rochester, like they have Wegmans in their backyards. We actually don't have a lot of local donors, so we have to think strategically how we work on a state across the country to get retail donations. Obviously there's a war going on, so we're worried about the cost of fuel, worried about the cost of food, worried about the cost of fertilizer and kind of the ripple effects and what that will bring to us in the coming months and next year. So yeah, what are we doing about this? We have a product sourcing plan. We are having conversations with donors, elected officials like you all, of how, if we have to continue to purchase food, what does this look like? We want to continue to be efficient in our operations. We operate at a 93% efficiency rate. We do the advocacy, like I mentioned. As part of Feeding America, we do a strong push on federal advocacy. We do a lot of state advocacy for our state funding, obviously, and then having conversations here on the local level. And just being nimble and changing if we need to, pivoting. A lot of us who are at the food bank were there during COVID, and we always talk about how we kind of like went through war together. Being able to think creatively and be able to pivot and respond quickly depending on kind of the current climate. So yeah, how can we work with the county? There is this statewide program called Nutrition Outreach Education Program that here in Tompkins, Catholic Charities has held the contract. Because of the cuts on SNAP Ed on the federal level, New York State has changed the structure of that program. So we have actually submitted an application, a joint application with Catholic Charities to try to keep SNAP outreach going. But the grant has been cut by 50%. So we have to try to backfill that with public funding. Local ag support, so this past year, our network of pantries got a $25,000 contract through the county to purchase local product to kind of try to replace the loss of the Local Food Purchasing Act product that ended a few years ago. So thinking creatively about how we want to support our local ag and getting that food into pantries. And then finally, I want to shout out to Tompkins Food Future, and Katie is here. Katie actually moved over to the food bank almost a year ago now from Cooperative Extension. So her work has traditionally had a fair amount of county support, and she's implementing the action plan for that group. So that's kind of some places I see overlap with the county. And that was a lot of talking on stats, so happy to answer any questions from you all.
Questions? Christy and Rachel?
I'm just curious, you were talking about retail donations. Do the Ithaca College and Cornell, do they donate to the food bank?
We actually have pantries at both locations. We do get a fair amount of donated product from the Cornell farm. I think with the food scraps recycling law phase 2, that I think like the Statler Hotel and certain restaurants are gonna mandate that they have to donate, but we don't actually get donated food from either Cornell or IC outside of the farm, to my knowledge right now.
Right. I also just want to comment, I really love how easy the website makes it for people to donate or give a gift. That's the very first thing that you see when you go on there, so.
Cool. Should be if you need food, but. Right. And I do want to, we actually just implemented a new food finder, find food on our website that's mobile optimized, that hopefully is a lot easier for people to find food, but also it is good for people to be able to donate if they need to. Yeah, those are the two, like the purpose of the website. It's like, we want to raise money, but also make sure people can find resources. Yep. Thank you.
Rach?
Thank you for the presentation. For the $200,000 that comes from Tompkins County, so for the food that is purchased using that money, do the pantries within Tompkins County still have to pay for it? I guess my question is, I know that the average, you said the average amount per pound is 13 cents to a pantry, but if a pantry is buying food for a couple, a few hundred to 600 people a week, then that adds up. And
yep. So how it works is we get the contract, we set up an internal grant that we allocate to the pantries, so they get a portion of that amount based on their size and their service numbers. Some of them that last them a long time, some of them spend through it really quickly. So once they go through that, if they also get state grants from us. So essentially it's like, they draw down on a grant, then they go on to another grant, and then they draw down that. If they spend it all, then they have to dip into their own funding. So it really depends on each pantry. Again, some of them can stretch it out the whole year. Some of it's gone in a couple months. Some pantries spend 50 grand with us. Actually, Cornell spends like $300,000 with us each year. It's crazy because they're literally just buying food. Yeah, I hope that answers your question. But they get the grant, they spend it down, and if they have to pitch in after, so they'll get, it's a wholesale, it's kind of like shopping at Costco. When they do have to actually purchase, it's a discounted price, but yep, they have to start paying.
No, that makes sense. I am familiar with the catalog, so I was more curious if that money went to kind of a general fund at the food bank, and then you were using it to buy wholesale, or whether it goes, that's all the money that goes directly.
We're kind of like a fiscal admin, and then we voucher to the county, and then we get reimbursed for that.
Okay. And my other question was if you have any sense whether there's going to be any talk of a state program that would be similar to the LFPA that was around last year, the New York Families?
There was a bill last year to create a similar program. I think one of the concerns I had is it sounds like it replicates Nourish New York, because we do have a state program very similar, but they wanted it to replace it. And I think part of it was like state politics, that they wanted it separate and branded by the legislator. It didn't pass last year, but there is momentum behind that. I think our concern obviously with the state budget is what's going to happen next year, especially if the SNAP cost shift hits New York State budget. I think they're going to start looking at all of these programs. They're going to look at SNAP outreach, funding to food banks in one bucket. And if they're like, well, now we have to put money into SNAP admin over here, we're going to take it away from these programs for food banks and pantries. So I get worried that a program like that would be a harder sell when we're backfilling all these federal cuts.
Any other questions? Well, thank you for joining us today.
Thank you all. It's good for me to get out. Thank you.
We have 2 more items of business before we depart. I forgot to do advisory board appointments. Health and Human Services, Community Mental Health Service Board, Substance Use Subcommittee. Antonia Pellegrini, community member, term expires December 31st, 2029. William Sonnenstall, community member, term expires December 31st, 2029. Do I have a mover? Christy moves, Veronica seconds. All those in favor? And that's unanimous. Brittany, you are here now. Do you have anything that you want to share from DSS?
Hello. I'm not sure if anyone gave the advisory council update at all.
Corsa started to, and then he said it'd be better for me and Brittany to do it together. He is now gone, so if we want to do that in August, that's fine.
If you want to what? Sorry, cut out.
If we want to do that in August when you both are here at the same time, that's fine.
Yeah, so we did meet, and we will be prepared to give you guys a update on the advisory council at the August meeting. We met with Katrina, and we're going to work on developing the bylaws and be ready to start appointing people to the council in January. And we'll be ready to provide a full update to you guys next month. It is an advisory council that will be appointed by the commissioner, and they would report to the commissioner, and then we can have someone who is part of the legislature that is sitting on the board with us, or the council with us, and we'll be ready to provide a full briefing in August.
All right. Anything else?
Not today. There's a lot going on today, and I'm just not prepared to give a whole bunch of updates.
Anybody have any questions for Britt? All right, that's it. Thank you for joining.
Thank you.
I hope the day gets a little easier to sort out.
Thanks.
Does any committee members have anything they want to share? All right, with that being said, there being no further business before this committee, this meeting is adjourned.